In this video, we're going to talk about dementia versus delirium. And the key to this is to differentiate. It's based on time, meaning dementia is something that's happened over the course of a long period versus delirium should have happened within the week or even days. And when it comes to dementia, I want you to categorize everything, and then we're going to know pretty much kind of a cause and one clear defining trait of each one. And if you do that, you should be able to kind of navigate your way through these step questions.
Alright guys, so here's our pretty much our video for the dementia versus delirium. First question is going to read, it says an 80-year-old female is brought to her PCP, primary care provider, by her assisted living facility after she's been increasingly reported seeing people walk through the walls of her room. Prior to coming to the ALF, which is assisted living facility, she was living by herself until she had been calling 911 frequently after accusing neighbors from stealing her personal property. Her past medical history reveals dementia diagnosis and urinary incontinence. Which of the following is most associated with the probable diagnosis? So anytime on the STEP exam, if you see someone pretty, kind of elevated age, that's had something chronic, you got to be thinking at least dementia. When it comes some type of behavioral disturbance, you got to be thinking dementia. Now, the key with dementia is you got to put it into basically just run the list of categories, and what that is, you can easily go PICS, Lewy Body. Okay, because these are our two that we really differentiate, and then you have the Alzheimer's, which is kind of a default. Nothing looks like it's really a PICS or looks like it's a Lewy Body. Then you kind of default to Alzheimer's, and then after that, you can start thinking Parkinson's, or the lesser known ones are the B12 deficiency, the how do you spell that? Creutzfeldt, Jakob. And so on, okay? But these are the ones that they're mainly going to hit you with. But again, this is dementia. This is a gradual. Now look back at this one. This person's in an assisted living facility. She's seeing people walk through the walls. Now this has been ongoing, right? Because when she was back at home, she was accusing her neighbors of doing some of that perhaps semi-delusional stuff, okay? So she's 80. It's been long going, I guess you could say. And then, so out of all these choices, the one where you have visual hallucinations, the visual hallucinations is going to go with Lewy Body, okay? Visual hallucinations. PICS, you're going to think it's a personality change, right? For some reason, they become aggressive. There's just a drastic personality, gradual personality change mainly, okay? And then Alzheimer's, this is kind of the, it's kind of like the default, okay? Everybody knows kind of like that one. It's just if it doesn't fit those, it's Alzheimer's. And then, of course, you have the Parkinson's, which is almost like a dementia with a gait disturbance, okay? And, with that, you get the tremor, rigidity, and then, of course, B12 and the Creutzfeldt Jakob are two of the separate ones. So know these. Know the basics of personality change PICS, visual hallucinations, Lewy Body. You default, last pick is Alzheimer's, and then if it's dementia with the gait disturbance, you got to be thinking Parkinson's. Now, back to this question. This person obviously she's old, she has visual hallucinations. We're definitely going with Lewy Body, but of course on step one, they're just not going to say Lewy Body. They're going to say, what is associated with this? Now, we talked about this before. Alzheimer's, you better be thinking presenilin 1, presenilin 2, and amyloid precursor protein on chromosome 21. That is for early onset Alzheimer's, okay? Presenilin 1, presenilin 2, amyloid precursor protein, chromosome 21, early onset. What did we say was late onset? The ApoE4, right? And which one was protective? ApoE2. There's four, number 4 letters, L-A-T-E, late, okay? Now, prions. What are prions associated with? Oh, well, prions are going to be our whole Creutzfeldt Jakob, right? Prion disease, where that's more of a, sudden, over weeks to months of a personality change. But usually there's a better, they're not having visual hallucinations per se. But again, you would have to have the prions. You know, I don't know how they're really going to get that other than autopsy. And then this alpha-synuclein. Alpha-synuclein, it's going to be associated with the Lewy body. Okay, also associated with Parkinson's, but the best choice on this one's going to be Lewy body is going to be with the alpha-synuclein. Neurofibrillary tangles goes with Alzheimer's, right? Oligoclonal bands goes with MS. Frontotemporal atrophy, PICS, okay? Frontotemporal, I'm just going to put FTD. Frontotemporal atrophy goes with PICS. You can see on step 1, you're going to have to make the diagnosis. They're never going to give it to you as an answer choice. You got to know the details behind it. So make sure you know all these answer choices and where to put them. This one says, a 60-year-old male is brought to his primary care physician by his family due to increasing erratic behaviors over the past 9 months. They report back that in public he is sexually inappropriate with women and can be uncharacteristically rude with people he has known for years. They report that one of his older brothers had similar issues. Routine lab work, CBC, complete metabolic, TSH, B12, all return normal. Now that's key because remember, a lot of these are the modifiable factors. Anytime somebody comes in that's old, or really in general, but especially when someone's old, you got to do the basic lab work for the things that are modifiable, because if the TSH is all over the place, or the guy's deficient in B12, or that can impact it, and you don't want to stick some diagnosis on somebody when the condition is modifiable. So you always do that first. But those all came back with the normal limits. MRI reveals frontotemporal atrophy. Okay, and which of the following is associated with the patient's diagnosis? Well, obviously they're 68. When you get 65 and older, we've got to start thinking about the dementias, right? And how do we do that? We say, oh, we got PICS, we got Lewy body, and we got Alzheimer's as our default. And then, of course, we can start thinking about Parkinson's, we can think about B12, and then we can think about the Creutzfeldt-Jakob one, right? All right. So, with that being said, when we see frontotemporal atrophy, we better be jumping all over what? Frontotemporal atrophy, we better be thinking that would be PICS disease, right? So frontal temporal atrophy, you got to be thinking PICS now, but of course they're not going to put PICS here. You got to say which of these is associated with PICS. Now, what we can do is, we know presenilin 1, presenilin 2 is amyloid precursor protein associated with Alzheimer's. I just did this one. And then ApoE4, late onset Alzheimer's. ApoE2, it's protective, okay? Protective for Alzheimer's. You're lucky if you got that. Neurofibrillary tangles, Alzheimer's. Now, of course, you're going to get answer choice like this: intracellular aggregated tau protein, intracellular phosphorylated tau protein. Okay, now how are you supposed to know these? Well, that's why you're watching the video, right? Because this is a slight difference between the two. The phosphorylated tau protein goes with the Alzheimer's. The aggregated tau protein is going to go with PICS. Therefore, answer choice E. Okay? Yeah, that's kind of a tough one, right? There's no doubt about that one. That one's a bit of a tough question. But you got to know the details that go with all the dementias. Again, PICS, we got the, it's a personality change associated with aggregated tau proteins. Lewy body, it's a visual hallucinations associated with that alpha-synuclein. Alzheimer's, associated early onset, presenilin 1, presenilin 2, amyloid precursor protein. Early onset. Late onset, ApoE4, protective. ApoE2, also seeing neurofibrillary tangles. Okay? This one says, a 70-year-old man is brought to the emergency room by his assisted living facility after increasing agitation over the last week. He started accusing staff of stealing from his room and was heard during dinner time talking to his wife, who passed away 4 years ago. He recently started taking over-the-counter meds for sleep. Past medical history is positive for hypertension and takes metoprolol. Urine toxicology screening is unremarkable. CBC, unremarkable. Which of the following is most likely diagnosis? So we have we have an older gentleman, right? And we got to be thinking, we have to be what on our differential? We got to be thinking dementia, but it's all based on time too, right? But it's over the last week is when he had these kind of issues. Just because he's sitting in an assisted living doesn't mean he's too far gone. So it's occurred within last week. So we also have to be thinking about delirium. Okay, dementia, gradual. Delirium, more sudden. Okay. Now, if it's delirium and it's sudden, we got to be thinking like an infection. We got to look at labs, make sure it's not that there's not CBCs not all over the place. It could be meds, it could be drugs. Now, the true mnemonic acronym I used to say, and you don't need this for step 1. Okay, this is more of a step 3 kind of thing. It's the I watch death, and that runs you through all the things you should look for with delirium. But for step 1, you just have to know that when someone goes off the rails and it's a sudden change, okay? It's a sudden change. It's not like this guy was having agitation or personality changes for months or years. This happened over the last week, so we got to be thinking delirium. Now, what's the cause of it? The CBC was normal. Now, that doesn't rule out the possibility of infection. Maybe he's not producing white blood cells, but it doesn't give us. They got to give us something on the step exam. In real life, we still dig, but so I'm not getting too much of a feeling that it's infection. Now, it could be what he recently started. Look for medications that they started, or they went to their primary doctor for something. There's always like a question on there sometimes of someone taking lithium and then they have like knee pain and start taking ibuprofen, and then they get toxic and stuff like that. Okay, but in this one, he started taking over-the-counter medication for sleep. Well, what's all that over-the-counter sleep medication have in it? Diphenhydramine, right? Benadryl. What is it? It's very anti-cholinergic. Very anti-cholinergic. And I'll make sure that at some point I do like a, kind of a farm-esque video, because this is so super important, that the anti-cholinergic medications, acetylcholine, and things that go against that. So in this situation, it's most likely from the sleep medication. They take Benadryl and things go off the rocker. When you're studying for step 1, don't take the Benadryl because it does affect with the memory. So in this situation, it looks like delirium. But of course, on your answer choices, they have bereavement. Now, this guy's wife died many years ago, and bereavement's just a normal process, okay? So there's no signs that this is what's causing these issues with the agitation over the last week. Acute stress reaction. Now, acute stress reaction is more like a trauma. Let's just say like it could have been like an assault. It could be like trauma from war. It could have been a car wreck, but it happens like 1 day to 30 days, okay? Very sudden. If that happens 1 to 30 days and you're kind of like, I can't sleep, I can't do this, it looks like PTSD, but you haven't been at least 30 days. If it hadn't been at least 30 days, then you gotta call it a acute stress reaction. If it's 30 days or more, you fall into PTSD. But again, that doesn't apply to this question. Metoprolol toxicity, well, that's a beta blocker. If he was toxic, I don't think delirium would be one of the things that I would perhaps see. And I'm saying it can't rule it out because we're all different, but I'm not seeing that this one's really an answer choice, that there's got to be better ones. Metabolic encephalopathy or major neurocognitive disorder. Now, major neurocognitive disorder is just another name for essentially like dementia. Usually when you put a diagnosis in, you put major neurocognitive disorder, comma, dementia, comma, and then what type of dementia it is, okay? So we feel that this is more sudden, it's not gradual, it's not a major neurocognitive, it's actually a metabolic encephalopathy, it's more of a delirium presentation. And I better say, you better know delirium for step 1. You better know delirium for step 1, step 2, and step 3. But remember, it's sudden. And as you go to step 2 and 3, just know the mnemonic I watch death. It talks about infection, withdrawal, alcohol, things like that. Okay? This one says, a 55-year-old who is a and I do a better job spelling these things, who is known alcoholic, is brought to his primary care for evaluation and clearance for placement in a living facility, as he is no longer able to care for himself due to his chronic lack of self-care. His lab work is unremarkable other than slightly elevated liver enzymes, okay, AST, ALT, MCVs 102, and TSH return here. Homocysteine levels are elevated, and methylmalonic levels are elevated as well. Which of the following is most associated with the elevation of the methylmalonic acid levels? Wow. So this is biochemistry, and honestly, I will be doing a biochemistry one, so no worries on that, because this is something that I struggled with, but it became very interesting and very crucial, especially for step 1. But back to this question. When I see this guy, he's a known alcoholic, right? And they give us all this lab work. The AST and ALT are slightly elevated. AST more than the ALT, right? I think normal here would be 40, and over here would be max 20. So the AST, and of course, an alcoholic, AST should be greater than the ALT, right? That's kind of like a kind of a known thing. MCV being 102. Well, when the MCV is elevated, this is one of the labs that I always look for on question stems, because when the MCV is elevated, I either think B12 or folate, right? TSH is well, that's normal, right? I always think TSH 45 cents to $4.50 per se, and as long as it fits in there, it's going to be normal. If you didn't know that, again, on the top part of your your computer, I guess, when you're in the testing center, will have the labs, and you can just click on it if you don't know that. Now, homocysteine levels are elevated and methylmalonic are elevated. Wow, so you're thinking, how am I supposed to know that? Well, that's part of the biochemistry, but it applies to this dementia, delirium kind of esque thing because we're talking about B12, folate, and these are modifiable factors, okay? So they could hit you with this. Now, of course, answer choice A is going to be thiamine deficiency, but thiamine deficiency has nothing to do with this methylmalonic acid levels. Now, could it be associated with alcoholism? Absolutely, but that wouldn't explain the methylmalonic acid levels. And hyper and hypothyroid, just based on this TSH, we don't have any additional information. Could it be possible that the TSH is normal with a elevated T or low T4? Possible, but they'd have to give it to us in the question. So they didn't, so I'm down to B12 deficiency and folate deficiency. Now, if you get into the whole, and biochem's really not that hard after you get a couple principles down, the isocitrate, alpha ketoglutarate, goes around to succinyl-CoA, and I'm not going to bore you with the whole, the whole Krebs cycle. But there's a thing that happens right here that goes into this succinyl-CoA. It's called methylmalonyl-CoA, and so I always say methylmalonic acid. And one of the cofactors per se is going to be B12. Very specific, okay? It's very specific to this guy. So if I don't, and this is a good differentiator between the two, because if I don't have the B12, what's going to happen? If I don't have this guy and things are naturally go in this direction, if I don't have that guy, who's going to build up? Who's going to go higher and stuff? It's going to be this guy, right? And you can see that if the B12 was normal, okay, if the B12 was actually good, and this elevation was just due to folate per se, then I wouldn't have the elevation of the methylmalonic acid. It would be normal. But the fact is, it's actually elevated, and I have to go that it's a B12 deficiency, because then actually in the B12 and the folate, the homocysteine can be elevated in those deficiencies, right? It's semi non-specific on that, but the one that is very specific, the one that you're going to have to differentiate on, is going to be this methylmalonic acid. Okay, and again, threw that one in there because it kind of applies to the dementia aspect of it, guys. So, with that being said, it is more of the dementia versus delirium video. So just one more time through it. If it's delirium, if it's sudden, you're going with delirium. Think meds, think infection, okay? you kind of a UTI is kind of the most common one that they like to do on that. If it's dementia, I want you to think either Lewy Body, I want you to think PICS, I want you to default to Alzheimer's if you don't know. You're going to throw in Parkinson's if you see some type of gait disturbance. And then you can get into the obscure things of B12, Creutzfeldt-Jakob, all that kind of stuff. Now, again, Lewy Body, you're talking the visual. PICS, you're going to do the personality change. Alzheimer's, you're going to say it's presenilin 1, presenilin 2, amyloid precursor protein, neurofibrillary tangles. ApoE4 is late onset, ApoE2 is protective, and so on. So you should be able to kind of rattle through those guys, and you got to keep moving forward. So hope this helps.